So I've kind of got a couple of things to touch on. We kind of briefly mentioned kind of how we've organized the task force. And what we're looking at is we're looking at about 5 different domains in terms of prevention, education, emergency care, law enforcement, and treatment. And the thing about it is if we can do the prevention side, then we don't need the other 4 dimensions because we will handle it at that point. So that's really what we're trying to uh, focus on there for our task force. And I actually think we were making some headway when 2 years ago, I think we had 103, or maybe if I forget the exact number, but it was there was more prescriptions for opioids than there were people in Sebastian County. And we were right at the average for the state. And then we actually got below 100, which I was real excited about. And I think because of COVID, we haven't seen data for this last year. But if we're following the national trends, it's gone up. It's gone the wrong direction. And when you look at it, and I kind of briefly did a literature review, just kind of see where we were countrywide. And one area that we don't think about as being part of our catchment area, but it certainly is the Indian Health Service. They're seeing a huge increase in opioid-related issues, and they come here. I mean, they come to Mercy and they come to Baptist because we're the nearest tertiary referral center for them. So we get those patients frequently. Annals of Internal Medicine, they looked at the different factors on the increase in opioid use and opioid use disorder. And one of the things that I hadn't really thought about, but is definitely an issue, is the disruption of care for people that are on medication-assisted therapy, which is both a treatment and a prevention. We're trying to prevent a relapse. But because of COVID, they've lost access to some of their physicians. Now, fortunately, CMS did go back and relax some of their regulations and restrictions regarding MAT and who can do it and the number of patients can be in their panel. But I don't think that our providers locally know that. And so that falls into that education piece again. And educating our providers is something that we're definitely trying to do from the task force. We do have an unfortunate intersection for socioeconomic status between the COVID-19 pandemic and the opioid overuse epidemic. And it was found that compared with white patients, our African-American populations are disproportionately affected by both pandemic and epidemic issues. And they have a higher mortality and higher hospitalization rates. CDC's noted that we've had an overall increase in overdose deaths over the last year. So, and they're watching that pretty closely. It's a little disheartening from the medical side because I think like I said, I felt like we were getting some headway and that we may have lost some of that traction. On the bright side, some of the things that we've been able to do in the county, I recently signed for Fort Smith Public Schools an expansion of the Narcan availability. I know Bill Hollenbeck got his officers trained up for that, and so that's been deployed in our school systems. I will continue to reauthorize that for anyone who wants it, pretty much. So I think I've got Chief Baker's officers as well as our county officers, and I think Barling, and we've got one other jurisdiction, Lavaca maybe, that we've got covered, and I'm all for expanding that access as well. And as an aside, I'd love to hear about it anytime that's used successfully. But if you look at our total statistics for the United States, we're looking at for the DEA, 37 of 38 U.S. jurisdictions reported increase in synthetic opioid-involved overdose deaths. So that's not the fentanyl or the heroin that's coming in over the border. That is prescription opioids. And so that's something that we can actually stop if we work at it and start with that prevention. We're teaching our residents right now in our program. I call it the 3 for 3, which is 3 doses a day for 3 days, and then you stop. So if you come in with a fractured ankle or you come in with a kidney stone or something like that, we're not gonna let you be in pain, but we're also not gonna overtreat you, because if it's that overtreatment that starts people down that pathway. And it's our fault. I mean, and by our fault, I mean society and government and regulation. For the longest time, we had pain as the 10th vital sign or the 6th vital sign in the ER. And we were being judged by how well we were managing people's pain, and people got afraid to not. And, the reality is that Tylenol and ibuprofen work pretty well, and we need to use that and deploy that more effectively. And so that's some education there, both for patients and what to ask for, and for our prescribers and what to give. So We've had some legislative successes as well. We're mandating prescription opioid training for all licensed providers in the state. And, we've actually provided some of that education. I think we've managed to get our summit to count for that. At least that's how I've reported it. And, we've got several people on our task force that are legislators that are involved in, in helping us frame some of the laws to make things a little easier. The last thing I'll say, and I didn't realize it until we were asked, but last year the Arkansas Hospital Association asked Sheriff Runyon and I to come down and talk to them at their annual meeting about the successes we were having in Sebastian County, which I think Hobie and I were both somewhat surprised that we were having successes in Sebastian County. And so we were pretty happy to find out that apparently we're a leader in the state for this sort of community approach to it. And the one thing I did point out at that meeting was the most important thing we have is a busybody, and that would be Pat. So she makes us do stuff and show up to meetings, and she always makes sure I have coffee at meetings. And that's the important thing. So we're very lucky to have her. She's kind of the one that's the driving force behind all of it. That's the comments I've got.
Doc, Paul Chapman here. I had a question. You gave a percentage of folks that were using prescription drugs, I guess, at overdose. What was that percentage again?
I don't know. That's exactly what I was talking about. I talked about the number of prescriptions we had per capita in Sebastian County, and that's from the PDMP data that we get. And I don't know that I talked about specific prescription percentages. There is an increase of greater than 50% in 18 of the DEA jurisdictions that are monitoring this. There's 10 Western states, which we don't count at. We're more central, but there's 10 Western states that reported a 98% increase in synthetic opioid involved deaths. So we start looking at that Western column of states that goes from Oklahoma on up. You're looking at almost a doubling in opioid death rates. So otherwise, I don't think I mentioned any specific percentages.
Okay.
I think he was talking about when you said 103 prescriptions.
Right.
Yeah.
Yeah, at one point we were at 103 prescriptions per. Yeah, here we go. That's the slide. But you'll notice that we're down to 90.5, which is we're now below. We were right at average. Now we're below average, and we're below that 100 prescription benchmark, which I think is great. You look at counties like Stone or Montgomery or Pike, and they're basically on fire. And we managed to get our rate down to 90.5, but that's a huge decrease. I mean, I think that points to some of the successes we've had with our efforts. And as I said earlier, it's a combined effort across many disciplines, and that's what I think is being successful. I mean, all of us add a little bit, and it turns into one big thing at the end. So
Heather, would you roll to that slide that has all the drugs listed on it? Then it's up a little bit higher.
That's Karen doing the rolling, but yes, she can.
Yeah. Okay. So Dr. Clardy, can you talk about this slide just a sec about just when we think about the numbers of drugs that are on the street?
Well, and that's one of the bigger problems is it's the leftover and unused prescriptions that high school kids get access to, or we see a lot of people that are sharing medicines. It's like, well, I had a kidney stone a couple months ago. Here, you can have the rest of my Percocet. Well, that's because they were given 30 tablets instead of 9. So, and I get it. I mean, you as a physician, people come to me because something hurts, and it's my job to make it not hurt anymore. And so that's a very basic level. That's what we do. But when you start looking at the number of pills available, that's where it starts getting really pretty dramatic. Some of these that they've got here, like this muscle relaxant slide they have here, the muscle relaxants themselves aren't an issue. It's the problem is that they potentiate other opioids and can increase your risk for opioid death or mortality or morbidity. So Zolpidem is mostly just expensive. I just wish it wasn't on the market.